Assalamu alaikum, my dear students. Hopefully all of you are safe and all your beloved ones and you are enjoying the distant learning so far. Today we're going to have another lecture about the toxicity of corrosives. So common household items such as cleaners, detergents, auto supplies, and paint may contain dangerous chemicals. Additionally, occupational exposure to hazardous chemicals and caustic substances is very common all over the world. In this lecture, we are going to discuss the toxicity of injuries following the exposures to corrosives and chemical burns. These are my expected learning outcomes for this lecture. Moving into the mood of toxicity. Potentially dangerous chemicals can be found in every room in your home and used in many industries and occupations. If you don't make sure that the necessary precautions for storing and handling these dangerous substances are fulfilled, then accidental toxicity is very common to happen, especially when children are around. Accidents with corrosives can range from minor injuries to serious and life-threatening and fatal conditions for all age groups. Accidental toxicity is the most common mode of toxicity. Suicide and homicide can also happen. Suicide, especially in rural areas, happen by ingesting carbolic acid. It is a commonly available chemical that is used very often in cleaning, but it's also cheap and is known to cause rapid, painless death. This is why it is used as a suicidal method. Also, it's been reported that some homicidal crimes happen after throwing corrosive material on a victim to cause disfigurement or mutilation. This kind of crimes is known as acid attacks and happen all over the world. If you can recall, 2 years ago, there was an internet challenge that got very popular among teenagers in the United States, where they were ingesting laundry tabs, this kind of laundry detergent, and this challenge caused severe injuries to many teenagers and children. Even they had in the supermarkets to close all the containers with locks to make sure kids and teenagers have no access to them in the store without supervision. However, we need to keep in mind that most household cleaning products and pesticides are reasonably safe when used as directed, and that the level of toxicity of a product is dependent on the dose of the product used. So never use more than the amount listed on the label, and the length of exposure to the product. If we can simply classify these hazardous chemicals, it will follow under two main categories: organic corrosives or inorganic corrosives. Organic corrosives have mild local toxic effects. However, they perform severe remote toxicity by action on the systemic organs. Examples would be carbolic acids, I just mentioned that, it's known also as phenol, and oxalic acid. And we will discuss this in details later on in this lecture. The inorganic corrosives are known to have a severe local effect on the tissues they contact with. Except for hydrofluoric acid, strong inorganic corrosives have no remote action, and they only cause severe burn when they get in touch with tissues, skin or eye or GIT mucosa. Examples of strong corrosives would be either strong acids such as sulfuric acid, nitric acid, and hydrofluoric acid, or strong alkalis such as sodium hydroxide, potassium hydroxide, ammonium hydroxide. Now we're going to talk about strong acids and alkalis. The strength of an acid is defined by how easily it gives up the proton. The strength of the base, however, is determined by how avidly it binds a proton. Acidity and alkalinity are measured using a pH scale for which 7 is neutral. The lower a substance pH less than 7, the more acidic it is. And the higher a substance pH greater than 7, the more alkaline it is. As you can see in this picture, among the strongest acids is the battery liquid. And the strongest alkali is the drain cleaner. And both of them are considered to be household items. So accidents are very likely to happen using these compounds. Starting with sulfuric acid, it's been used in many ways by many different people. It can be used in everyday life, and it is also known in Arabic as mayat al-nar. It's used in many industries. So this slide shows some of the many applications where sulfuric acid is used. You can see that it includes the manufacture of fertilizers, rubber, making other kind of products and acids, detergents, dyes, and some medicine, and even in oil refining industries. Speaking about nitric acid, it is a strong oxidizing agent and it enhances the combustion of other substances. Therefore, it is used in the manufacture of explosive. It is also known to make plant grow faster, so it's extensively used in fertilizers. Another use of nitric acid would be in the labs to identify different metals in very diluted form. It is used to assess the purity of gold, especially in low-grade alloys, as it dissolves all metals except gold and platinum. Sodium hydroxide, we're moving to alkalis. So sodium hydroxide is one of the strongest alkali, also known as ley or caustic soda. In Arabic, it is called the soda al-kawiyah. Sodium hydroxide is used in the manufacture of soaps, rayon, which is a kind of fabrics, paper, also in petroleum refining. At homes, it is used in drain cleaners and oven cleaners. Solutions of sodium hydroxide in water are at the upper, most basic compound on the pH scale. Potassium hydroxide, it is also called caustic potassium. In Arabic, it is also called potas. The purified material is a white solid that is commercially available in the form of pellets and flakes. Like sodium hydroxide, it is very, very strong alkali, very soluble in water, and very highly corrosive. It is useful in a variety of applications. It is used in variety of industries, such as manufacturing soaps, batteries, fuel cells, fertilizers, biodiesels. When it is dissolved in water, actually it gives a liquid very similar to milk. Therefore, it is commonly mistaken by young children for milk, leading to many accidents with severe injuries. Ammonium hydroxide uses can be found in the bathroom, floor, glass, carpet, metal, upholstery, or kind of cleaners, as well as in starches, disinfectant, and stain treaters. Most household ammonia contain up to 5 to 10% of ammonium hydroxide. Other products include auto care, such as tire inflators, fiberglass cleaners, metal cleaners, and polishes. It is also present in some cosmetics, such as mascaras and lash colorants, used in explosives, fertilizers, hair care products, hair dyes and hair glazes, and hair touch-up kits. So, also some personal care products, such as shaving creams and lotions, acne treatments. So many products. Ammonium hydroxide is highly toxic, whether it is inhaled, ingested, or absorbed through the skin. When it comes in direct contact with the eyes, can cause blindness if not washed away immediately, within at least 10 seconds. When skin contact occur, it can cause burns and blisters. Ammonia is also toxic when it is ingested and causes extreme corrosive to tissues. Now, speaking about bleach, sodium hypochlorite. So chlorides are the primary chemical used in bleaches. One of the commonest household products that is used for cleaning and sanitization purposes. The reason for that, it is very cheap and yet very effective. Household bleach is alkaline with a pH of 11 to 12. It is dilute enough that is when used at homes it is minimally irritating to the skin. More concentrated form used in industries may cause severe damage and corrosive injuries. Besides being irritant to the respiratory tracts. The problem with bleach is that sometimes it is mixed with other acids and alkalis, leading to elaboration of toxic gases. These toxic gases may be fatal, causing chemical asphyxia. When mixed with acids, bleach forms chlorine gas, while when mixed with alkali, it produces a chloramine gas. Speaking about the mechanism of toxicity. So, as we know now, corrosive substances have local, rapid, and destructive action when they come into contact with tissues. However, alkalis and acids can cause damage by two different mechanisms. They don't cause the classic hyperthermic burns, like in flames and fires. However, heat generation contributes to tissue damage. Again, remember, strong inorganic corrosives have no remote action, unlike organic acids, except for hydrofluoric acid, and we're going to discuss this in details later. Let's first speak about the pathophysiology mechanisms of acids. So, all cells and tissues in our body are composed of protein molecules. As you may recall from biochemistry, protein form the architecture for our body, especially in tissues like skin. Our skin is made of cells rich in proteins like keratin, which gives our skin structure and protection, and it also has elastin and collagen, which maintain skin flexibility. Acids donate protons, which change the chemical structure of proteins in a process called denaturations. When a protein denatures, it loses its shape and thus its function. So it loses the shape and the function of this protein with the protein denaturation. During the denaturation process for the skin is exposed to an acid, the cells die but do not dissolve. So the cells die but they don't disintegrate. The result is a scar. It's usually clear or white patch of skin that is no longer alive but acts as a placeholder for once living tissue. This process is called coagulative necrosis. The benefit for this non-living tissue is that it makes the burn less severe compared to burns with alkali chemicals. The dead tissue, we call it a coagulum or eschar, prevents the acid from reaching deeper tissues, making the burn more superficial. With acid ingestion, the stomach is the main organ affected, while the esophagus is less affected because common strong acids are usually available as liquids, so they slide quickly to affect the stomach rather than injuring the esophagus. Now, moving into alkalis. As we previously mentioned, alkalis are chemicals that accept protons, also known as bases, and alkalis that accept protons easily are stronger alkalis. Just the opposite of acids, stronger alkalis have a higher pH, with the strongest having a pH of 14. Alkalis, however, do not create coagulum, but rather cause liquefaction necrosis, which means that cells liquefy and dissolve. This creates a pocket of gooey tissue that allows the alkalis to leach into the deeper structures in the body. Alkalis denature proteins, but they also break down fats in a process called saponification. Burns from alkalis tend to be much worse than burns from acids. Further injury is caused by thrombosis of the blood vessels. Alkalis most severely affect the squamous epithelium of the esophagus, but the stomach only affected in 20% of cases. Hydrofluoric acid. It is a chemical compound that contains fluorine. It can exist as a colorless gas or a fuming liquid, or it can be dissolved in water. When hydrogen fluoride is dissolved in water, it may be called hydrofluoric acid. Hydrogen fluoride can be released when other fluoride-containing compounds, such as ammonium fluoride, are combined with water. Despite it is an inorganic acid, it has both local action and systematic action. The local action, hydrofluoric acid, is also known as flesh-eating acid. So the burn is very severe that may reach into the underlying bones. The systematic effect happen when the fluoride ions are released into the cells. Fluoride ions inhibit glycolytic enzymes and combine with calcium and magnesium to form insoluble complexes. The extreme local pain is believed to result from calcium immobilization, which leads to nerve stimulation by shifting potassium ions. Acute fluorosis can occur as a result of the fluoride ions entering the systematic circulation, resulting in cardiac, respiratory, gastrointestinal, and neurological symptoms. Severe hypocalcemia, which is resistant to very large doses of calcium, may occur. The cause of death is cardiac arrhythmias due to electrolyte imbalance. The severity of burns. The severity of the chemical burn is related to several factors, including the pH of the agent. pH less than 2 and more than 11 cause severe damage. The concentration of the agent. Concentrated forms of acids and alkalis generate significant heat, which when diluted or neutralized, which is resulting in thermal and acoustic injury. The length of the time of contact is very important. The volume of the offending agent is very significant in determining the amount of injury. The physical form of the agent. So ingestion of solid pellets of alkaline substances results in prolonged contact time in the stomach. Thus leads to more severe burns. In cases of ingestion, the presence of food in the stomach may alter the effect of the caustic agent on the gastrointestinal tissue. When talking about the clinical manifestation, ocular burns consist of burns to the sclera, conjunctiva, cornea, and eyelids. Happens with ocular splashes. Chemical burns, particularly those involving the cornea, are considered true ophthalmologic emergency and require prompt assessment and intervention to minimize the morbidity. The severity of an ocular burn is directly correlated with the duration of exposure and the causative agent. Skin manifestation resulting from the direct contact of the acid with the dermal tissue, and it will be in the form of burns and scars. The late manifestation happen if the patient survive include scarring, deformity, and disfigurement that is sometimes very difficult to be corrected by surgical intervention. In this picture, we see some ocular injuries following exposure to corrosive materials. So alkali substances can pass into the anterior chamber rapidly due to the inability to buffer alkali in the eye within approximately 5 to 15 minutes. This exposing the iris, the ciliary body, the lens, and the trabecular network to further damage. Irreversible damage occur at a pH value above 11.5. Acid burns causes protein coagulation in the corneal epithelium, which limits the further presentation. As a rule, these burns are non-progressive and very superficial. You can see here in the picture, injury of the cornea leads to early new vascularization, very red eyes, and here is the corneal opacities. Chemical burns here showing in this picture. You can see the irregular pitted appearance of the injury of the skin. This is because of caustic soda exposure. You can see the patchy skins and the infection. This picture shows exposure to hydrochloric acid. In the first picture here on the left, the picture shows the burn before removal of the blisters. Here on the right side, you can see the burn after removing the blisters, and you can see that these patches of white coagulum or eschars of coagulative necrosis. These are some of the clinical manifestations that appear when the respiratory system is exposed to the caustic substance by inhalation of fumes or ingestion. Findings of shortness of breath, hoarseness, and stridor suggest laryngeal trauma and demand laryngoscopic evaluation. As you can see in this photo, the white patches in the mucosa of the larynx and the epiglottis after the ingestion of alkaline material. Clinical manifestation. The GIT manifestation include pain, excessive salivation, dysphagia, and vomiting. Hematemesis usually is indication of perforation. So sometimes patient with minimal ingestion may be asymptomatic, but other may experience oropharyngeal, retrosternal, or epigastric pain. Usually dysphagia, odynophagia, and excessive salivation are suggestive of esophageal damage. Abdominal pain, vomiting, hematemesis may suggest gastric damage. Continued pain and tachycardia, persistent high leukocytic count, and acidosis, pleural effusion, this should raise the suspicion of perforation. This picture shows the caustic injury after ingestion of acid material. See, the esophagus here there is no noticeable injuries here in comparison to the stomach, which is widespread severe injury. This picture shows the endoscopic grading of caustic injury and the GIT. Picture number A indicates only slight swelling and redness of the esophageal mucosa. Grade 2A is shown here in picture B, the presence of superficial ulcers, bleeding, and exudate. So this localized patches here. Grade 2B indicates local or encircling deep ulceration. So deep ulceration in this picture. Picture D shows grade 3A, which indicates focal necrosis, shown here by the white arrows. It shows focal necrosis, and then grade E, picture E shows grade 3B, which shows extensive necrosis, severe necrotic injury here in this picture. This picture shows diffuse liquefaction necrosis of the entire esophagus after ingestion of alkaline substance, and this is the barium swallow after 4 months following caustic injury. There's a long stricture here in the distal esophagus and the gastric cardia. You can see in the picture. This picture shows resected stomach following a perforation after caustic substance ingestion. The picture on the right here is the gross picture and shows the perforation here by the arrow. Also on the picture on the right shows the inside of the stomach with marked necrosis of the gastric mucosa. Complications. So the long-term effect of caustic dermal burn is scarring, which depends on the site of the burn. Scarring can be very significant. Scarring, infection, and poor healing may occur with dermal burns, and this will require skin grafting. Ocular burns, especially from alkali substances and hydrofluoric acid, can result in cataract formation and or complete loss of vision. Perforation and or bleeding and respiratory compromise from upper respiratory edema and complication of caustic ingestion. But stricture happens in long-term complications with caustic burns to the esophagus. Sometimes it is transformed into malignancy, leading to carcinoma of the esophagus. First aid measures. So, bronchite wound irrigation with lukewarm water is the most critical aspect in limiting the extent of dermal burn from exposure to caustic substances. And many experimental studies showed that the irrigation following the exposure to strong acids and alkali within several minutes neutralize the pH change of the dermal tissues and decrease the damage of the affected areas. Additionally, clinical studies have shown that patients who received irrigation within 10 minutes following injury had a 5-fold decrease in fold thickness injury. So we prevent contaminated, also it is important to prevent contaminated irrigation solution from running into the unaffected skin areas. Also removing contaminated corrosives is a very essential step. In case of ocular exposure, eye irrigation should be started immediately. Actually, this is a very important slide, and I would like to emphasize the contraindication shown here. These are some of the contraindications that medical professionals need to avoid when dealing with chemical burns. Never induce vomiting, as it may cause further damage to the GIT and lead to aspiration pneumonia. Oral fluids will also induce further damage by running the caustic substance further through the distal GIT. Activated charcoal is contraindicated because it may infiltrate burned tissue and interfere with endoscopic evaluation later on. Attempts to neutralize a caustic acid by giving alkalis or a caustic alkali by giving acidic materials are contraindicated because severe exothermic reaction may result, and this will lead to further damage of the tissues. Lastly, insertion of a nasogastric tube is contraindicated because it can damage already compromised mucosal surface. A dilution with milk or water only is useful in the first few minutes after ingestion of liquid caustic, but delayed dilution may be useful after ingestion of solid caustics. Dilution should be avoided if the patient have nausea, drooling, stridor, abdominal pain, or any indication of perforation. Elimination has no rule in this area of toxicity, and there is no available antidote, a specific antidote for these chemicals. And moving into management, so after the patient is transferred into the emergency department, the physician should get detailed history, trying to figure out what is the chemical involved in this injury. Also physical examination, followed by lab tests that include arterial blood gases, complete blood picture, chemistry, including blood sugar level. Renal function test is essential, and also urine analysis. We also we perform coagulation profile to detect the presence of DIC and septicemia. Moving into radiology, for ingestion, consider chest radiography if there is any respiratory symptoms. Abdominal radiography also in the flat and upright position if there is signs of peritonitis is present. All patients with persistent vomiting, oral burns, drooling, or abdominal pain require further investigation to define the extent of the injury and risk for future complication. This means performing an endoscopy within 24 hours. But there is also another evidence that CT can be used as an alternative within 24 hours. Endoscopy is contraindicated in suspicion of perforation and airway damage. Patients who are asymptomatic at 4 hours and tolerating oral fluids can be medically cleared, no need for ICU admission. Symptomatic patients usually need to remain nothing by mouth and are admitted for observation and further investigation for at least 24 hours. Management is then directed depend on the condition of the patient. Patients with airway compromise will require urgent intubation and ventilation, which indicates admission to the ICU. Patients with hemodynamic instability or evidence of perforation any evidence of perforation will require urgent surgical intervention and ICU admission. Long-term monitoring includes dermal burn. In case of dermal burn, they treat it as an outpatient basis and should be checked every 2 to 3 days. Ocular burn also can be treated as the outpatient basis and checked every 2 to 3 days. Endoscopic examination of all transmucosal or transmural esophageal burn should be repeated into 2 to 3 weeks. Now we're going to start moving into organic acids. The first one we're going to talk about is carbolic acid, also known as phenol. This is a highly flammable compound that is a derivative from benzene. It is also called benzenol, and it is a highly corrosive chemical, which is well absorbed by all routes of exposure, including inhalation, cutaneous, or oral ingestion. It has a characteristic carbolic odor and a sweetish, pungent taste. Several commercial products are synthesized from a precursor containing phenol. Commercial products that contain phenol derivatives have different famous names, such as Lysol and Dettol. It is also among the active ingredients in local antiseptic medications to treat sore throat, surprisingly. It is important to mention that phenol derivatives are present in many households and personal products such as laundry detergents, air freshener, all-purpose cleaners, deodorants, and hand lotions. In concentrated form of carbolic acid, the one shown in the lower picture here, the common forms of toxicity are either suicidal, due to easy access to the product. As I mentioned before, it is cheap and causes painless death, or it is accidental, especially with children and workers, as it is easily absorbed through the intact skin. The mechanism of toxicity. So phenols denature and precipitate cellular proteins and result in tissue injury in the form of superficial ulcer. It is also characterized by painless injury due to the anesthetic effect on the sensory nerve endings. Systematically, it is considered as one of the general protoplasmic poison. You should recall this term from the lecture for heavy metal toxicity. It causes central nervous system stimulation followed by depression. It also has a direct effect on the heart, causing myocardial depression and cardiac arrest. It disrupts the acid-base balance in the body, leading to either respiratory alkalosis as a result from a respiratory center depression, or a metabolic acidosis resulting from renal failure. The toxic effect on the kidney is in the form of acute glomerulonephritis, and it also can cause a methemoglobinemia. Clinical presentations of acute poisoning is called carbolism. In the local injuries, we can see skin ulcers, which white chars with the smell of phenol. It usually turns brown with oxidation. Also burning, tingling sensation, and numbness of the affected area due to affection of the sensory nerve endings. On the GIT, If it's ingested, it starts by vomiting. We can see the phenolic smell of the vomitus. Then itchar around the mouth following the ingestion. Difficulty in speech and swallowing due to anesthetic effect on the cranial nerves. Clinical presentation on the systematic level, it includes CNS, we can see constricted pupils, convulsions, followed by depression and coma. CVS include hypotension, arrhythmias, and cardiac arrest. Kidneys include oliguria, albuminuria, hemoglobinuria until it is total anuria. Also, it is important to mention it causes frothy green urine due to the phenol byproduct excreted in urine known as hydroquinones and catecholamines. Differential diagnosis. When this chemical picture is very similar to the picture by opium overdose. So both of them has constricted pupils, and there is convulsions, whereas followed by depression and coma. However, we can smell the phenol smell in cases of phenol toxicity, and there is the colored ulcers or scar of on the tissues. So the colored scars of the injured tissues. The cause of this is usually respiratory failure in early cases of death, following renal failure in late cases. Management, of course, after the patient goes to the ER, if history is available, a detailed history is very important, especially occupational history. A clinical examination, if looking for the findings we just discussed. Laboratory work would include arterial blood gases to detect alkalosis or acidosis, kidney function tests, urine analysis, detection of methemoglobin level. Also, ECG is very essential to detect for the cardiac abnormalities and monitor the cardiac functions. Treatment starts by supportive measures, the ABC, as you all know. Emesis is contraindicated in this condition because of the high chances of seizures and coma. Gastric lavage is indicated and highly recommended as vomiting temporarily and usually stops shortly as the anesthetic effect of carbolic acid progress. It is also relatively safe as the coagulative necrosis causes a thickening of the gastric mucosa and perforation is not likely to happen. Furthermore, gastric lavage reduces the systematic effect of phenol as it helps eliminate the amount ingested. Gastric lavage may be performed by ethanol 10% as it dissolves the phenol in the stomach and it is easily washed out. In case of eye contact, irrigation using water or saline is indicated for at least 15 minutes. Elimination of the absorbed poison can be done by dialysis in cases of renal failure. Charcoal hemoperfusion or exchange transfusion is also can be helpful. No specific antidote for carbolic acid, and other symptomatic treatment measures are indicated according to the clinical presentation. Diazepam is recommended for convulsion, acid-base correction, and treatment of methemoglobinemia with methylene blue. Lastly, we're going to talk about oxalic acid. So oxalic acid is an organic corrosive acid. It's a constituent of many household products. It's found in many disinfectants, household bleaches, metal cleaning liquids, anti-rust products, and furniture polishes. Oxalic acid is found in several green leafy vegetables such as spinach, broccoli, carrots, cabbage, lettuce. It is also occur in fruits such as berries and grapes, figs and plums, along with in some seeds. Also, it's present in some seeds such as nuts and grains. Oxalic acid is a colorless, transparent, prismatic crystals. It has sour taste. It is strongly acidic. When it is soluble, oxalic acid solution has irritating corrosive effect on the skin and the mucous membranes. If ingested, it causes hypocalcemia, as it binds with the free calcium ions in the body and causes precipitation of this in the form of insoluble calcium oxalate crystals, especially in the parenchymatous organs such as the brain, the heart, and the kidneys. Insoluble calcium oxalate salt found in Diaphantaceae plant. This is one of the household plants and similar plants, and it is not absorbed, but it causes local mucus irritation and skin irritation. The clinical presentation. Toxicity result of skin or eye contact is inhalation or ingestion, so by all routes. Acute skin or eye contact causes irritation and burning, which may lead to serious corrosive injury if the exposure and the concentration are high. Inhalation may cause sore throat, cough, wheezing. Large exposures may lead to chemical pneumonitis or pulmonary edema. Ingestion of soluble oxalates may result in weakness, tetany, convulsions, cardiac arrest due to profound hypocalcemia. The QT interval may be prolonged and variable. Conduction defect may happen. Oxalate crystals may be also found in urine analysis. Kidney failure may happen due to the obstruction of the collecting tubules of the kidneys by the calcium oxalate crystal precipitation. This will lead to oliguria, anuria, and end by uremia. So management is also include health history. Occupational history is of very significant, as I mentioned before. Clinical manifestation detecting the local and systematic symptoms and signs. Laboratory work include very important to include the kidney function test, urine analysis, and serum electrolyte. Also ECG to detect the cardiac abnormalities and monitor the heart functions. When it comes to treatment of oxalate toxicity means calcium by every possible route. We start by the supportive measures, ABCs, as you know, airway, breathing, and circulations to stabilize the patient. Then GIT decontamination. Gastric lavage is essential and it is indicated. We have to remove the calcium oxalate crystals inside the stomach. So the GIT contamination is performed through mainly through gastric lavage. And we use calcium containing solutions and avoid water, as water may lead to dissolve more of the acid and increase the absorption. Elimination of the absorbed poison sometimes requires dialysis, and oral or slow IV 10% calcium gluconate is essential to treat hypocalcemia, and it is considered as a specific antidote for this poison. Other measures include treatment of the symptoms as diazepam for convulsions, IV fluid to protect the kidney from the damage by the calcium oxalate crystals precipitation in the renal tubules. So, to summarize this lecture, I would like to emphasize that household chemicals have many caustic chemicals that is very dangerous. Sorry, it's supposed to be that are very dangerous if not handled with necessary precautions. Strong acids and strong alkalis have different pathophysiological mechanisms of energy. We have to differentiate between these two different mechanisms. Please remember that organic acids have local and systematic effects as well as hydrofluoric acid. So hydrofluoric acid is the only inorganic acid with both local and remote actions. In the management of chemical burns, it is contraindicated to induce emesis nor perform gastric lavage. And finally, supportive care of the patient is the main line of treatment in case of injuries. These are links for self-learning materials. If you have time to do that, that would be great. And my take-home message to you is to take care of yourself and your family and follow strict precautions when storing and handling household products containing caustic chemicals. Make sure they are stored in locked cabinet out of reach of children. Also wear protective clothes and gloves whenever you need to use these chemicals to make sure that you are safe. And thank you so much for attention. This is my email. If you need to ask about anything, please don't hesitate to send me an email. I will be happy to answer all of your questions. And again, thank you for attention.